Welcome everyone to Grand Rounds today. We have a very exciting speaker. Well, I'm biased, but I'm here to introduce Dr. Christopher Celano. Dr. Christopher Celano is a psychiatrist, associate director of the Cardiac Psychiatry Research Program at Massachusetts General Hospital, and an associate professor of psychiatry at Harvard Medical School. Dr. Celano's research focuses on the development and implementation of interventions to promote mental and physical health in individuals with cardiovascular disease. He has served as the principal investigator of NIH and foundation-funded studies to develop and implement health behavior interventions, including an ongoing R1-funded project to evaluate the efficacy of a psychological intervention to promote adherence in heart failure. He has also served as the principal or co-investigator of multiple other projects related to health behavior promotion or use of collaborative care to better identify and treat depression and anxiety disorders in individuals with heart disease. He has published over 110 articles, including over 70 original research articles and 5 meta-analyses, and he has presented the results of his work at both national and international conferences. His talk today will focus on the management of depression and anxiety in patients with cardiovascular disease, as well as promoting health, well-being and health behavior and adherence in this population. As a cardiac psychiatrist, I'm personally very excited to learn from him today. But I'm also certain that these topics will have broad applicability to those of us working with patients with other complex chronic medical conditions. And now, without further ado, please welcome Dr. Celano. This is how you know I'm not Dr. Rosenberg. So a couple housekeepings. So those of us in-house, please hold on to your questions at the end, and you can come to the microphone afterwards to ask your questions to Dr. Celano. Those of us joining us via Zoom, your chat is disabled, but you do have the QA box, so please enter your questions in the QA box and we will get to them at the end of the talk. And lastly, please remember to fill out the evaluation forms at the end. Now really, without further ado, Dr. Celano.
Thank you very much. So my name is Chris Celano. I'm from Mass General in Boston, and I'm very excited to talk about cardiac psychiatry today. I have no real disclosures other than that I get some honoraria from Elsevier from some editorial work. So what I'm going to do today is spend a little bit of time talking first about depression and anxiety in patients with heart disease. I'll talk a little bit about how common they are, their relationships with heart disease, and then how we go about diagnosing and treating those disorders in these patients. And then in the second part of the talk, I'll spend a little bit of time talking about well-being, trying to think about how we can cultivate well-being and what we can do for our patients to help them feel more positive, and whether or not that may actually have cardiovascular benefits as well. So to start, I wanted to talk about depression and anxiety in patients with heart disease. So these disorders are very common in patients with heart disease. About 30% of folks with heart disease have elevated levels of depression or anxiety, and about 15% actually meet criteria for major depressive disorder or generalized anxiety disorder, which is about twice what you would see in the general population. This is common across multiple types of cardiovascular diseases, including coronary artery disease, heart failure, atrial fibrillation, and other things like that. So one question that comes up really focuses on what is the relationship between these disorders and cardiovascular health. And when we think about this, there are really two different kinds of epidemiological studies that are typically done. One might take folks who do not have heart disease, you measure depression or anxiety, and then you follow them over the course of 10 to 20 years, and you want to see whether or not depression or anxiety is associated with the development of heart disease or its progression. The other kind of study actually takes people in that middle dot who have a heart disease diagnosis already. You then measure depression or anxiety, and then you follow them over the course of years to see if it increases their risk of developing complications. Now, depression is the psychological symptom that is really kind of most consistently associated with both the development and the progression of cardiovascular disease. We know that when people are healthy, from a cardiac standpoint, if they are depressed, they're at higher risk of developing heart disease. And if you have heart disease, you're more likely to have a recurrent cardiac event or die from heart disease. This relationship is so clear that the American Heart Association actually identifies depression as a risk factor for poor cardiac outcomes following acute coronary syndromes. Now, the relationship between anxiety and cardiovascular health is a little bit less clear. If you take healthy people and you measure anxiety and then you follow them over time, anxiety certainly does appear to increase the risk of heart disease. But if you take people with heart disease, a lot of other things kind of come into play. If you measure anxiety during kind of a stable period, when somebody has stable coronary artery disease, it does seem as though it does predict outcomes. But if you measure it right after an acute cardiac event, or if you measure it in patients with heart failure, the relationships don't appear to be clearly there. And I think that there are probably two things that can kind of help to explain this. I think in the first thing is that if you measure anxiety following an acute cardiac event, anxiety can be really normal for a lot of people during those times. So kind of thinking about whether or not that's something that's problematic is kind of harder to do. And then with folks with heart failure, I think there's just a lot of overlap in symptoms between anxiety and heart failure symptoms, which I think can also make it just really hard to see the relationships that might actually be there. I think this is supported by the relationships between anxiety disorders and cardiovascular outcomes. If we think about anxiety disorders, these are situations where people have chronically elevated levels of stress or anxiety that end up kind of impairing their function over a long period of time. And I think as a result of that, it's pretty clear that multiple kinds of anxiety disorders actually are associated with both the development and the progression of heart disease of multiple kinds. I think anxiety disorders actually are much more important to screen for than just looking at anxiety in general. So if you were to screen for something, I would certainly try to make an anxiety disorder diagnosis, because on the one hand, it's associated with cardiovascular outcomes more clearly. And on the second hand, it's really something that we know how to treat. So we definitely have treatments for anxiety disorders in a much better way than we do for anxiety. So if we know that anxiety and depression are associated with heart disease, the question comes up as to how are they related? And there have been a number of studies that have really identified both potential biological and behavioral mechanisms that might explain these relationships. In terms of biological mechanisms, we know that depression and anxiety both affect serotonin, and that there are also serotonin receptors on platelets. And when people are depressed or anxious, their platelets actually get a little bit more clumpy. So they're more likely to form clots, which can have kind of different types of implications for multiple types of heart disease. Similarly, depression and anxiety are associated with multiple elevated levels of biomarkers like interleukin-6 or C-reactive protein that we know are also implicated in the pathogenesis of cardiovascular disease. They're also associated with elevated markers of endothelial dysfunction. So the endothelium is kind of the inner lining of your arteries that kind of go to your heart and to all of the other parts of your body. And this ends up making those arteries kind of less likely to actually vasodilate during periods of areas of stenosis, which can end up being kind of particularly significant for patients with coronary artery disease. And then finally, depression and anxiety are associated with sympathetic hyperactivity and parasympathetic hypoactivity, which means that this leads to kind of elevations in heart rate and blood pressure that put more strain on the heart than you typically need to have. Now, most of the studies that have looked at biological mechanisms really are cross-sectional studies and relatively small, and so we don't know the direction of these relationships, whether depression and anxiety are causing these and these lead to the health outcomes, or if maybe these are markers of cardiovascular disease that also manifest as depressive symptoms or anxiety. What we do know more about are behavioral mechanisms, and those are the things that we tend to focus on in our research group a little bit more. We know that when you're depressed and anxious, your diet tends to be worse. You eat fewer fruits and vegetables, more fats and other kinds of things that are less healthy. You're less likely to be physically active. You're less likely to take medications or engage in programs that are potentially helpful for your heart, like cardiac rehab. And then you're also more likely to smoke or use alcohol, which can certainly affect your heart in multiple ways. So depression and anxiety are associated with cardiovascular health, potentially through these different ways. And the question becomes kind of how do we actually make a diagnosis? So I think one of the biggest challenges with making a diagnosis in the setting of depression and anxiety and heart disease is that there's a big overlap between those psychiatric symptoms that we experience and the physical symptoms that go along with heart disease. So just As an example, these are the diagnostic criteria for major depressive disorder and generalized anxiety disorder. And if we think about a patient with heart failure, a lot of these symptoms end up overlapping substantially with what we would see in patients with heart failure. So you can see kind of weight change, sleep disturbance, fatigue, muscle tension. It's really hard to actually kind of figure out and tease out which symptoms are related to the psychiatric problem and which are really just related to heart failure symptoms. So when I think about actually making a diagnosis, I usually try to think of a few things. First off, I really want to make an actual diagnosis. So really looking at the cardinal symptoms of depression or anxiety, thinking about depressed mood or anhedonia, or anxiety and difficulty controlling it, end up being really important in terms of making a diagnosis. If somebody doesn't have those things, I'm going to be less likely to think that it's a psychiatric problem. The second thing is really thinking about the timeline. So we know that depression and anxiety disorders start early in life, kind of like in your 20s and your 30s. And most of the folks with heart disease are, several decades down the line. So if somebody has no history of depression or anxiety and for the first time is presenting with these symptoms when they're 70 years old, that's going to at least make me think about it and wonder whether, whether I'm thinking about the same thing. One of the things that I oftentimes like to do is really think about the time course of the symptoms. Like, did the symptoms coincide with a heart failure exacerbation or anginal symptoms that somebody's having with CAD? And if so, I might actually defer treatment and try to reevaluate the person once they're a little bit better and once their kind of cardiac symptoms are a little bit better controlled. So we know that depression and anxiety are common, and so screening is actually recommended by a number of different organizations for patients with heart disease. The American Heart Association recommends using the PHQ-2 and the PHQ-9, which really are just the 9 diagnostic criteria for major depressive disorder for patients who have cardiovascular disease. And the United States Preventive Services Task Force recommends screening for anxiety in all adults using a similar tool called the GAD-2 and the GAD-7, which are just the diagnostic criteria for generalized anxiety disorder. I think that using these tools certainly seems reasonable from my perspective, as long as you're using them as an aid to make a diagnosis, as opposed to just using a cutoff score for elevated symptoms. So if you actually make the diagnosis of depression or an anxiety disorder, there are a number of different treatment options that we typically think about. Psychotherapy, pharmacotherapy, and then collaborative care, which is something that our group has done a bunch of work in. What I'd like to do for this part is really just tell you a little bit about where the evidence base stands for each of these different types of treatments for these folks. So in terms of psychotherapy in patients with coronary artery disease, the only psychotherapy that has really systematically been studied is CBT. And so the biggest study that has studied CBT is the ENRICH trial. This actually came out kind of over 20 years ago. And this was a randomized controlled trial of CBT for patients who were post-MI, so about 2,400 of them. And they had to have either major or minor depression or low perceived social support. So not all these folks had major depressive disorder. Actually, a minority of them did. And some of them didn't even have depression at all. So which in my mind would make me think that whatever results we got would probably be better in patients with major depressive disorder, because we know that treating more severe depression is usually more effective than treating minor depression or no depression. Regardless, people got 6 60-minute sessions of CBT as part of the program. And then importantly, if people were in the treatment group and had severe depression, or if they were not responding to CBT, they could also get antidepressant treatment, typically with an SSRI. This is kind of relevant, and I'm going to come back to that in a little bit. But in terms of the main outcomes, CBT was helpful. It led to modest improvements in depression and social support scores at the end of the intervention, but it didn't affect cardiovascular outcomes. And this is what you would typically see in most of the studies that look at psychotherapy or even the antidepressants in patients with heart disease. Now, since then, there have been a number of other CBT studies done. So this is just a meta-analysis from about 7 years ago, looking at 12 studies. They were randomized controlled trials of CBT for anxiety or depression in patients with CAD. Most of these studies utilized a cutoff score in terms of elevated depressive symptoms. So these were not necessarily folks with formal psychiatric diagnoses, and the comparator was almost always usual care. So this is just the main forest plot looking at the effects of CBT on depression. So anything to the left of that line in the middle is beneficial and favors the CBT group. Anything to the right doesn't favor the CBT group, it favors the control group. And what you can see by looking at that diamond at the bottom is that there was a significant improvement in depressive symptoms when using CBT in this population. The effect size was about negative 0.35, which is a small effect size, but it was statistically significant and shows that CBT does appear to be beneficial in this group. If you actually look at the forest plot for anxiety, it looks almost identical. There's a few fewer studies, and so our kind of diamond is wider than the last one, but it is about the same, negative 0.34 in terms of a standardized mean difference, and still statistically significant, so seemingly equally beneficial both for depression and anxiety. Now, in terms of treatment of depression in patients with heart failure, CBT is, again, the only psychotherapy that has really been looked at systematically, even though it's been less so than in patients with CAD. So this is a systematic review that looked at the effectiveness of CBT in patients with heart failure. The main outcome was depressive symptoms. They didn't all need to have major depressive disorder. And again, the comparator was usual care. And if you look at this, this is kind of essentially the same kind of graph that we just saw before. But the standardized mean difference, again, is negative 0.34, which is essentially the same as what we saw with patients with coronary artery disease. So CBT seems to work for both kinds of populations. And if you actually follow these folks over the course of 3 months, you can see that the effect size doesn't really change. So it seems like folks are probably learning skills in CBT that they can continue to use moving forward even after the end of the intervention, which is great. Now, in terms of pharmacotherapy, the main kinds of treatments that have been studied in patients with coronary artery disease are SSRIs, not surprisingly. And there have been a number of different randomized controlled trials looking at this. We've looked at sertraline, citalopram, escitalopram, and mirtazapine. And all of these studies basically randomize people to receive either the medication or placebo for either 12 or 24 weeks. And then we try to see whether or not it works. And fortunately, it looks like it works in almost all of the different cases in looking at CAD patients. I would say the effect sizes, again, are relatively modest. They tend to improve kind of psychiatric outcomes. None of these trials were really powered to look at cardiovascular outcomes. And at the length of time that they were kind of done, you wouldn't really expect to see a difference in cardiovascular outcomes either. Now, when we think about pharmacotherapy for depression in the setting of heart failure, again, SSRIs are the things that have been primarily been studied, but the story is a little bit different. There were a few kind of early pilot studies that suggested that antidepressants were helpful. And so there were two big randomized controlled trials that looked at this. SAD Heart CHF looked at sertraline, whereas the Mood HF trial looked at escitalopram. And both of these studies were completely negative studies. The Mood HF trial was actually stopped early because it wasn't going to work. It was kind of pretty clear partway through that both groups were improving similarly. So why do we kind of think, why is the question? Why do we think that this is the case? I had kind of a few hypotheses. I thought certainly potentially medical illness severity could be one thing. If we kind of took a look at those two studies, over 70% of folks in the SAD Heart CHF trial had New York Heart Association class 3 or 4 symptoms, which means like even with minimal activity, you have heart failure symptoms. And over half of the folks in the Mood HF trial had New York Heart Association class 3 or 4 symptoms. So that's one possibility. I'm not sure that both groups improved, and there was a placebo group, so you would imagine that it would affect both groups similarly. Depression severity, so both of the groups had kind of relatively low depression scores, only in the mild range, which kind of makes me wonder, number one, is this actually major depressive disorder? And also there wasn't much room to improve. Both of these studies used kind of outcome measures that have a lot of physical symptoms on them. So the Montgomery-Åsberg Depression Rating Scale and the Hamilton Depression Rating Scale. And so a lot of those symptoms you wouldn't expect to get better with an antidepressant. But I think the actual kind of answer is probably related to the study population. So if we kind of took a look at these folks, the average age was 62 and a half. And when we take a look at whether or not they have a history of depression, over 80% of those folks had no history of depression before entering into the study. So they were experiencing their first depressive episode at this point. And as I mentioned earlier, depression typically happens much earlier in your life than in your 60s. And so my suspicion would be that these folks actually didn't really have major depressive disorder, the vast majority of them. And so it's kind of not surprising that a medication's not going to work for them. This is a challenge for like almost all clinical trials where you're trying to recruit people and get enough people for your study in as quick a time as possible. But then you can't actually get people who you're actually looking for. So one way that we tried to look at this, so this is kind of from one of my colleagues in Germany. She and I took a look at some data from the Hopeful Heart trial, which was a randomized controlled trial of a blended collaborative care intervention in heart failure patients done by Bruce Roman and colleagues at the University of Pittsburgh. And we did latent class analysis to try to see who actually makes it into this study. So the way that folks needed to make it into the study was that they were using the PHQ-2. So folks needed to score at least a 1 on the PHQ-2 in the hospital when they're in the hospital for heart failure. And then 2 weeks later, they would give them the full PHQ-9, and folks needed to get a score of 10 or above to be eligible for this study. And so in our latent class analysis, we found that there were 4 different subcategories of people. There were folks who had mild depressive symptoms, moderate, moderately severe, and severe, with the vast majority of them being in the kind of mild to moderate range. And if we took a look at the actual symptoms that people scored on the PHQ-9, where they kind of had at least a 2 on one of the items, you can see that for the most part, these mild and moderate folks end up scoring primarily on these kind of sleep, fatigue, appetite types of items. And very few of them, less than half of them, actually kind of endorse depressed mood or anhedonia to kind of any degree. And if you actually look at these other folks, the kind of moderately severe to severe group, that's when you start to see suicidal ideation. That's when you start to see depressed mood and anhedonia, and a lot of the other kinds of changes that kind of happen kind of across the board. And so my suspicion is really that in a lot of these heart failure studies, we're just not getting the population that we typically want to get, which is those individuals with major depressive disorder. And so we can't really make a lot of conclusions based on kind of negative trials about antidepressants in this group. So I think if I actually if I'm seeing somebody with heart failure who has depression, I try to think about a few different things. Number one, I want to make sure that they have major depressive disorder. So I'm kind of going to look through the diagnostic criteria and make sure that it's accurate. I'm going to ask about the timeline and kind of think about whether it makes sense, whether they have a history of depression and whether the symptoms line up with their cardiac symptoms or not. I'm going to consider alternative treatments. If I don't think they really have major depressive disorder, I think those CBT studies I mentioned before, a lot of those folks didn't have major depression either, and it was beneficial for them. So I think if there are other tools or other things that we can do to help those folks, I would certainly potentially consider that before pharmacotherapy. And then I would really want to be realistic in terms of the treatment effects. So I'm going to think about which symptoms are most problematic for a patient, what's most important for them, and are there things that I can do to help them with that? And I would also want to think about their medical problems. Like, for example, if somebody is really having trouble sleeping, but their diuretic is being given at nighttime and they're getting up 4 or 5 times to go to the bathroom, adding another medication for sleep is not the answer. Like the answer is probably to move their medication, their diuretic to the morning, or to, work with them to try to think about how to cope with that. Now, I mentioned a lot of psychological outcomes thus far, but the question does come up about whether or not antidepressants actually have some type of cardiovascular benefit. And believe it or not, there is some evidence suggesting that they very well may. If we think back to that ENRICH study, which was the CBT study, I mentioned that folks who had more severe depression or those folks who were not responding to CBT could actually take an antidepressant. And when they went back and they looked at those folks who had an antidepressant versus those who didn't, those who had received an antidepressant actually were living longer and had a lower risk of mortality than those folks who didn't. This is kind of supported by a number of different registry studies that have been done looking at folks with cardiovascular disease or at risk of cardiac disease, where they find that if somebody has depression that is not treated, that kind of increases your risk of mortality. But if you actually treat the person by either referring them for psychotherapy or treating them with an antidepressant at a therapeutic dose, the risk is similar to those folks without depression at all. So you can actually kind of reverse this kind of risk factor, the risk factor of depression, by actually treating folks for their depression. And then there's some data from one of our randomized controlled trials. This was from the Estipox trial. So if you remember, this was a randomized controlled trial of escitalopram versus placebo. And most of the studies actually just followed people for 12 weeks or 24 weeks. But these folks actually followed people for 12 years. And when they actually went and took a look at whether or not folks randomized to escitalopram did better than folks randomized to placebo, they found that in fact they do. This effect doesn't start until after that first year. The first year, that kind of Kaplan-Meier curve is kind of the same. But afterwards, escitalopram actually has a protective effect in terms of major adverse cardiac events. Why would it take so much time? That's kind of a good question. I mean, I think I have a few hypotheses. I would think that number one, if you treat somebody's depression immediately following an acute coronary syndrome, they might actually be more likely to engage in health behaviors or go to cardiac rehab or do something that will end up having benefits kind of years later in terms of their heart health. Or there may be something biological going on where actually kind of treating depression might lead to reduced inflammation or reduced endothelial dysfunction or things that promote heart recovery following an acute cardiac event. And it's not just kind of using that particular antidepressant, but if you actually treat people to remission, if you get people better, they do better. They're kind of major adverse cardiac events, you have a 48% reduction in risk. All-cause mortality, over 50% reduction in risk, and similarly, you have a similar reduction in risk for PCI. So when I kind of like approach patients, and we've done some kind of collaborative care studies where we're screening people for depression or anxiety, and we kind of tell them, like, actually you're depressed when they didn't come to me, kind of like asking for help, and they're kind of skeptical about treatment. I really try to think about psychiatric treatment as like another component of their cardiovascular recovery, and trying to think about this as kind of a holistic approach for getting people better following their cardiac events. Now, the last kind of treatment that I want to talk about is collaborative care, which really isn't a kind of treatment. It's just a way of delivering pharmacotherapy or psychotherapy in an easier way. I'm sure a lot of people are familiar with this, but basically collaborative care involves having a care manager who's usually a social worker or a nurse who kind of talks to patients, screens them for depression or anxiety disorders, and then tries to coordinate treatment within the framework of existing care. So in this particular kind of situation, the care manager would give people questionnaires, monitor depression and anxiety severity. They would then talk with a group of experts, could be a psychiatrist and a psychologist. They could deliver short-term focused psychotherapy and could also make medication recommendations to the patient's primary care physician, who would do all of the prescribing to the patient. So this way, the patient never actually sees the psychologist or the psychiatrist, but gets kind of expert-informed care within the framework of primary care. Now, collaborative care interventions seem to be quite effective in patients with heart disease. We know that they improve psychiatric symptoms, they may improve some cardiovascular outcomes, and they certainly appear to be cost-saving. Now, our group kind of has done a couple of these collaborative care programs. One of the things that we've focused on is really identifying people in the hospital. And both of our programs, one in depression and one that looked at depression and anxiety, seem to improve mental health related quality of life, depression and anxiety symptoms significantly. Now, another kind of collaborative care that has come along kind of more recently is called blended collaborative care. It's actually not that new. It's kind of like 15 years old when Wayne Caton, published his main results from his teen care trial. But blended collaborative care basically involves adding some kind of specialist to your team. In this case, a cardiologist, if we're thinking about cardiac psychiatry. And rather than just focusing on treating depression and anxiety symptoms, the idea is that you're actually going to treat the cardiac symptoms as well. So you're going to reduce cardiac risk factors, manage blood pressure. If somebody has diabetes, manage diabetes, do all of the kinds of things that you would want to do to get people better. And kind of the biggest example of this in patients with coronary artery disease is the teen care trial. So this was published by Wayne Caton and colleagues from the University of Washington. And this study really involved using nurses as care managers rather than social workers. And the patients who were in this study were people who had either stable coronary artery disease or type 2 diabetes. And these nurses would work with patients to both kind of treat depression, but also work to kind of get their, improve their glycemic control and also modify cardiovascular risk factors. And when they did that, it actually worked, which is why it's in the New England Journal of Medicine. They were able to reduce hemoglobin A1C, reduce LDL cholesterol, reduce systolic blood pressure, and also reduce depressive symptoms at kind of a medium to large sized effect, which is about almost twice what we saw looking at the CBT studies that we talked about earlier. Now, in terms of blended collaborative care in heart failure, the biggest study that's looked at this is that Hopeful Heart trial that I mentioned before, done at the University of Pittsburgh. And in this particular trial, they randomized 629 folks to one of three groups. They could either get usual care, they could get enhanced usual care, which was basically collaborative care for heart failure, but not for depression, or they could get blended collaborative care, which was collaborative care both for heart failure and depression. And in terms of what they found that blended collaborative care did lead to better improvements in mental health related quality of life than usual care, with relatively small effects, and greater improvements in depressive symptoms than both usual care and enhanced usual care. And you can see that it was like substantially more beneficial than usual care with a medium effect size than it was compared to enhanced usual care, suggesting that these kinds of things are ultimately helpful. And then finally, our group just finished up a study called Total Health, which was a blended collaborative care program. So in this particular trial, we took folks who were hospitalized either for acute coronary syndrome or for heart failure. We had care managers who were nurses. They worked with folks on depressive symptoms or anxiety. They also worked to monitor cardiac symptoms and make medication recommendations from a cardiac perspective. And then they also tried to deliver different types of psychological interventions and help people set goals related to healthy behaviors. And then we had kind of weekly case reviews and care coordination with a cardiologist on our team, as well as a psychiatrist and a psychologist. So these are our kind of main outcomes. Our primary outcome was physical function at 26 weeks. And so we did not successfully improve physical function at 26 weeks. We did improve physical function at 52 weeks. And we also improved depressive symptoms at different time points and anxiety, as well as physical health-related quality of life and overall health-related quality of life at different time points. So again, it seems like these kinds of things are generally helpful, but probably, we need to kind of be doing multi-component interventions to target some of these symptoms. So in the last part of my talk, I really want to talk a little bit about well-being and heart health. So we were doing a lot of studies. We were recruiting a lot of participants from the inpatient units, and about 85% of them were not eligible for our studies. And we were like, what can we do with these people? Because we're already talking to them. We're already screening them for our studies. Is there a way that we can help these folks who don't actually have depression or anxiety? And one of the things we thought about was well-being. We were like, well, everybody can benefit from being kind of happier or more positive. And so this is kind of an area that we started kind of going down the route exploring. So first off, I want to just mention kind of what well-being looks like in the literature. And really, it looks like a lot of different things. There are a whole number of different positive emotions and constructs and terms and thoughts that people can have. And all of them are in the literature, and there's not a lot of consensus exactly about what each one means exactly and how we measure them. But here's just kind of a smattering of them. We sometimes kind of group them into different types. So some of the ones that are more focused on pleasure, we call hedonic well-being. Some of the ones that are more focused on purpose or meaning, we talk about as eudaimonic well-being. And then there are these other constructs like optimism, which is really positive thinking about the future, gratitude, which is more positive thinking about the past, and emotional vitality, which is kind of this feeling of connectedness to the present, so positive feelings in the present. And just like we thought about for depression and anxiety, we can do the same kinds of epidemiological studies looking at the relationships between well-being and heart disease. So I'm going to just mention two meta-analyses that look at this in healthy populations and then in cardiac populations. So about 8 years ago, there was a meta-analysis that looked at the impact of subjective well-being on mortality. They looked at 3 different types of well-being. They grouped them into evaluative, which was kind of, am I satisfied with my life or not? Experienced, which is really just kind of emotions. And then eudaimonic well-being, which is kind of this purpose and meaning. In terms of what this meta-analysis looked like, there were about 1.3 million people that were included in this. About half of the studies followed people for over 10 years. The most common type of well-being measured was eudaimonic well-being, and the most common outcome that was included was all-cause mortality. And in terms of what they found, in contrast to what we saw with depression and anxiety, well-being actually is protective in terms of mortality in our overall population with an 8% reduction in mortality risk. This is true among men and women. No differences between the two groups. It's good for you regardless. And it also is good for you regardless of the kind of well-being that you have. So all about kind of an 8 to 10% reduction in mortality risk. So well-being seems to be good if you're healthy. And if we take a look at folks in patients with heart disease, we find kind of similar things. So this is a meta-analysis that one of our research coordinators actually did back in 2015. And this was looking at kind of major adverse cardiac events and the relationships between well-being and those cardiac events. And we found that similarly, there was a 12% reduction in major adverse cardiac events compared to for people who are more positive compared to those who are less positive. So the mechanisms that we think about are really similar to what we would see in patients with depression and anxiety. In contrast to folks with depression and anxiety, well-being is kind of associated with more parasympathetic activity and less sympathetic hyperactivity, lower levels of inflammatory biomarkers, as well as kind of improved endothelial function. And similarly, when we think about people who are more positive, they're more likely to eat more fruits and vegetables, they're more likely to be physically active, they're more likely to take their medications, and they're less likely to smoke or use alcohol to excess. So we were kind of thinking about this, and we were trying to think about what we can do for our patient population, knowing kind of these different kinds of relationships. Like, are there ways that we can intervene to actually improve cardiovascular health? And so we started down this kind of multi-step process to develop some kind of treatment program to try to improve well-being and improve cardiovascular health. And we started by doing qualitative interviews with folks. So we did qualitative interviews in patients with acute coronary syndrome, heart failure, type 2 diabetes. This is from a patient with heart failure. But what we found kind of across all of those different populations is that there really is this reinforcing relationship between positive psychological well-being and health behaviors. So if you're feeling more positive, you're more likely to engage in a health behavior like physical activity. And then when you do the health behavior, not surprisingly, you feel more positive, and you're then more likely to keep wanting to do that health behavior again in the future. And so we started to think, okay, so we've got this cycle, this reinforcing relationship. Where can we kind of, intervene to kind of improve this? And we ultimately decided, why don't we just intervene on both of these things? So we ultimately kind of created an intervention that combined something called positive psychology with something called motivational interviewing. So everybody, I'm sure, knows what motivational interviewing is, but positive psychology really focuses on doing systematic activities to cultivate well-being. So these are very easy to do. They could involve writing a letter of gratitude to someone, performing an enjoyable or meaningful activity, performing acts of kindness for people, different kinds of things to get people more focused on, other people and well-being, and less focused on their cardiovascular disease, which is what a lot of these folks can spend their time focusing on. So just as an example of what these kinds of interventions look like, they're typically 8 to 12 weeks in duration. They're usually delivered by phone with a psychologist or a social worker talking to the participants every week. Everybody gets a treatment manual. They get some kind of educational materials. They might get an activity tracker to help keep track of activity, and other resources to keep track of diet and medication adherence. And then every week we try to get people to do these positive things. So this is kind of one example from our manual that kind of gives an overall rationale for why we're doing this, why we think it's important to improve well-being, and how we think that'll benefit cardiovascular health. This kind of talk is the start of our gratitude module. So it gives you kind of 4 different activities that we're going to perform over the course of the month. And then we give people specific instructions. So this is for gratitude for positive events, where we think about 3 different positive events from the past week. And then you write about them in your manual. You write about how it made you feel. And then every week you go over this with your study trainer, who kind of tries to expand your vocabulary of positive emotions and helps you to try to re-experience those emotions, and then kind of incorporate this into your daily life. We then combine that with motivational interviewing and a number of different goal-setting tools. We'll ask people to think about some health behavior they want to change, how important it is to change it, how confident they are that they can change it, and we work with them to kind of enhance their confidence and the importance level. We ask them about the pros and cons of behavior change. We help them to set SMART goals. We help them to kind of problem solve barriers and think about resources in their environment that might get them closer to where they want to be. And then we give them kind of places to actually kind of keep track of things. So they write their goals down, they have places to keep track of their activities. And then every week we are kind of meeting with them and then trying to encourage them to increase their goal in some way for the next week. We've gotten through kind of pilot studies for a number of our different study populations. This is an example of one of our randomized trials in patients with heart failure. And so this was positive psychology and motivational interviewing compared to an MI-based control condition alone. And what you can see is that we actually led to kind of medium to large sized effects on multiple different outcomes, including psychological outcomes as well as our health behavior outcomes. And so now we have 3 different randomized controlled trials going, looking at efficacy of these kinds of interventions in patients with acute coronary syndrome, type 2 diabetes, and heart failure. So the PEACE study is our kind of ACS study. BEHOLD is our type 2 diabetes study. And then we also have studies looking at folks who've undergone bariatric surgery for weight loss, in folks with metabolic syndrome, and then even in folks with irritable bowel syndrome. So do these kinds of programs actually work at helping people to feel better? So there was a meta-analysis done just 2 years ago by Ernst Bollmeyer's group in the Netherlands. This was looking at positive psychology-based interventions and their impact on well-being and distress. Distress really usually being either depression or anxiety. And what we found from these different kinds of, from this meta-analysis is that they actually seem to work. So these are again, our effect sizes. These are nearly identical to what we saw with CBT in patients with heart disease. And so these certainly seem like another option for kind of helping people to feel better. I think particularly for folks who do not necessarily have an actual psychiatric disorder like major depression or generalized anxiety disorder. Now, we have tried to think more recently about other ways of delivering these kinds of interventions. So one of the downsides of our phone-based interventions is that it takes a lot of time for our psychologists or our social workers, because not only are they talking to the participants, but then when the participant doesn't pick up, they're then trying to reschedule and all of this kind of stuff for hours and hours over the course of the study period. And so one thing that we came up with was thinking about text messaging. One thing that we liked about text messaging was that it was very simple and it was very cheap, so very kind of scalable from that perspective. And a lot of our older folks who are in our other studies don't have smartphones or are comfortable using different applications on their smartphones and are much more comfortable with text messaging, which just kind of shows up for them. And so one example of this is the kind of Text for Health program. So in this program, we were actually sending people daily text messages. They could be related to physical activity or diet or well-being. And each of these text messages had a number of different attributes. And people would kind of rate the utility of those messages every day. And over time, this program would kind of adapt to send people the kinds of messages that they particularly liked the most. We would also have people set health behavior goals and try to do different activities each week. So in terms of kind of feasibility and acceptability, it seemed like it was good. We were able to successfully deliver these messages. 84% of them received a response, which is much better than what you would typically see in kind of internet-based interventions or app-based interventions, where the drop-off happens very, very quickly and to a much greater extent. And people also kind of rated these as being potentially useful. In terms of our kind of main kind of preliminary efficacy outcomes, because this was a pilot trial, we did have relatively small effects on a number of things, as well as kind of some small, even kind of like bigger small effects on MVPA, optimism, and anxiety. With these kinds of interventions, the nice thing about text messages is that they're so cheap and you can kind of deploy them to so many people that you really, wouldn't expect them to have as much of an impact as like a phone-based intervention or a person-to-person intervention where there's a lot of provider time. But you can actually improve kind of population health in such a way by doing these kinds of interventions that lead to small beneficial effects in a much larger kind of group of people. So we also are doing kind of a number of other kinds of things. So our next steps in terms of these kind of messaging programs is we have one called Move with Meaning. So one of the things that we kind of noticed with our kind of text message programs was that we were trying to send a lot of content to people, which is sometimes hard to digest via text message. And so what we did was we kind of created a series of 8 podcasts. So every week people get texted a link to our podcast. It lasts about 20 minutes. They listen to it whenever they want. And then they can kind of set their goals using text messaging to try to see if that actually is helpful and works better. And then we're currently also developing another program called Dream, which is kind of taking some of our positive psychology and motivational interviewing work and having it be delivered through messaging using an AI-based chatbot. So having used this and having tested this out, it is like night and day better than what our typical text message interventions are. So I think that we'd still have to see whether people actually engage with it. But my experience kind of anecdotally is that it is like night and day better. And I think will be kind of like potentially very helpful for population health. So that's basically what I wanted to cover today. There are a few kind of clinical takeaways I wanted to leave you with. I think number one, mental health and cardiovascular health are one and the same. There are kind of these very strong relationships between the two that really are probably explained both by biological mechanisms and behavioral mechanisms. I think that if people do have a psychiatric disorder like depression or anxiety disorders, we should be trying to recognize them. We should be screening people. We should be trying to get them better. And if we do manage to get them better, I think it's actually going to have an impact not only on their psychiatric health, but also on their cardiovascular health. I do also think that especially for folks with heart failure, it's going to be hard to get people better. And so I think it's going to require something that requires multiple treatment modalities. And then finally, even when folks don't have psychiatric illnesses, we can help them feel better. Even if we're just encountering them kind of for another kind of purpose and they don't really meet criteria for something, there are plenty of things that we can do. We can help enhance well-being. We can help them to get more physically active. We can really encourage them in their recovery process. And I think that these are different ways that we can help folks feel better, both mentally and physically. So I do just want to thank my research team and some of the other folks who kind of made this possible, particularly Jeff Huffman, who is the director of our program and who is the PI for a lot of the studies that I mentioned. Certainly our kind of social workers, research fellows, and research coordinators, our funders, and my family who have supported me all the time. So with that, I'll stop and I'll take any questions. So thank you.
Thank you so much, Dr. Celano. I just want to mention that in addition to the folks you see here, we have 109 participants online, and we're going to try to take some questions. So if you have any questions, please step up to the microphone on both sides of the room and microphone.
This is, I'm sorry.
Okay,
Dr. Celano, that was incredible. I'm sorry. Oh, please.
No, go ahead. Go ahead, Dr. Wood.
That was incredible.
Thank you. I was arguing about which microphone I should use, but I got extra steps because I have such a positive psychological outlook. My question is about the escitalopram studies and sort of looking at the treatment effect after 12 years, particularly with regard to heart failure and cardiovascular outcomes. Is that with continuous treatment, or is it an initial episode of treatment of a finite duration and then those effects last? And I'm thinking partly because of the sort of national discussion about antidepressant medication, and also sort of how people feel about being long-term on those meds.
Yeah, no, that's a great question. So interestingly enough, I don't have the number exactly off the top of my head, but I think about 90% of folks had stopped escitalopram at 6 months. So everybody in the study was kind of tapered off of it, and very few folks actually remained on it over time. So these were not folks who were continually taking an antidepressant for 12 years. They were treated in the acute episode. Mm-hmm.
Thank you again. I think this especially hits home for me as an internist with a stethoscope at Psych Grand Rounds. Yeah, gosh, you have saved me a lit review and then some. I'm really wondering, do any of these studies include folks with SMI or substance use disorder? And then likewise, have you ever seen a collaborative care setting that includes cardiac rehab that we know is a mortality benefit for heart failure and CAD, and things like substance use disorder that is often either a driver of toxic cardiomyopathy or complicates obviously adherence to medications, follow-up, all that good stuff. Thanks so much.
Yeah, those are great questions. So I think the first question about SMI and substance use disorders, I don't know all the inclusion criteria from those studies, but my guess is that they would not have had those patients in there, that they would have excluded folks with serious mental illness and folks with kind of active substance use disorders. I think for most of our studies, we are usually excluding those folks because not that we will include folks if they have serious mental illness that is like stable and treated. But if there's kind of like active psychotic symptoms or something along those lines where we're not sure if we're going to be getting kind of reliable data on our questionnaires, that I think that's kind of the rationale for how that ends up happening. And then the active substance use treatment, we actually, I don't know, we don't have that for most of our studies. We include folks who have a substance use disorder, but I will say that it's really hard for those folks to actually get randomized in our trials because usually there's a bunch of hoops they have to jump through to get randomized. They have to like either wear an accelerometer and like do this and that and like come in for like 2 or 3 different visits, and those folks usually just kind of don't make it in terms of the engagement. So I think certainly kind of developing programs that are more tailored to that population would be would be awesome, would be great. And certainly seems to be a need. And I forget your second question. What was? Mm-hmm.
I'm sorry, the folks online cannot hear you unless you're at the microphone.
My other question was about collaborative care models, building off of the platform of cardiac rehab and the extended length of stay and all that offers.
Yeah, so there are not, I'm not aware of cardiac, of collaborative care that has built off of cardiac rehab, but that's certainly a great avenue to try to do that. And we've certainly thought about some of our health behavior interventions, whether we could kind of piggyback and continue after cardiac rehab, because it's such a good kind of start, but then kind of maintaining the change after people have kind of finished the rehab ends up being a big challenge. I will say there are some studies that have looked at kind of collaborative care for serious mental illness. I'm thinking Kelly Irwin is at Mass General as well, and she does some work looking at serious mental illness in a psycho-oncology setting. And so she has kind of like a collaborative care program that is much more intensive, like involving much more psychiatric provider time for those folks to help get them hospitalized if needed, get them through their different kinds of cancer treatments and stuff like that. So I think there is a recognition and a start for that.
I have two questions online with the same theme about your comments about the relationship between antidepressant use and sudden cardiac arrest or sudden death, especially with the recent study from Vienna.
Sure. So I think, one thing I didn't get into was kind of thinking about, QT prolongation or sudden cardiac death. That is an issue that kind of can come up with a number of different antidepressants. I would say that, I think that in terms of antidepressants and sudden cardiac death, I would be, most worried or concerned about tricyclic antidepressants and escitalopram and citalopram. Those are probably the three kinds of medications that are most consistently associated with the greatest degree of QT prolongation. But for the most part, the other kinds of medications that we're talking about, like sertraline would probably be my first line treatment for almost any kind of cardiac patient who has depression or anxiety disorder, if I was giving them a medication. And there's very little evidence that those other medications significantly kind of affect the QTC or increase the risk of sudden cardiac death.
Okay, well, thank you so much again, Dr. Celano.
Thank you.